Hi, folks. This is a mini lecture on stimulants. I'll be talking about the administration and the effects of stimulant drugs on the body. So for cocaine, there are several different ways that cocaine can be administered to the body. The first is chewing coca leaves. This is the longest, most historical use of cocaine. Coca leaves can be processed and turned into powder cocaine, which can be snorted. Freebasing, which is similar to crack cocaine, but more dangerous because it's basically, this is when, like I said in the history slide, the most potent part of cocaine, the base of cocaine, is freed from the other part of cocaine. And so it becomes more potent. And in order to process it to achieve that effect with freebasing, the person processing it uses ether, which is very flammable. So really freebasing isn't done very much anymore, especially after the invention of crack cocaine, which is processed with, I'm forgetting, baking soda, excuse me, processed with baking soda in order to isolate the base part of cocaine. Cocaine can also be administered via IV injection or smoking the crack cocaine, cocaine processed with baking powder. Amphetamines can be administered by snorting pills, smoking pot, which is a stimulating leaf. Pills can be swallowed to administer amphetamines, or they can be used in IVs as well. Cocaine and amphetamines, a little more detail into how they enter the body and the brain. So in the powder form of cocaine, snorting is a little bit slower to get into the bloodstream than the other forms of using cocaine. And so the level of cocaine in the body rises gradually. It peaks at about 30 minutes. Crack cocaine is smoked or heated, and the vapors that are released are inhaled, and the effects are as quick as what occurs with the IV injection, like 1 to 2 minutes, peaking in terms of level of sensation, the euphoria and the high feeling. Crack has a faster and more intense rush than snorting powder cocaine, and that also carries a greater risk of addiction and overdose because of it's the quicker to get high and the more intense rush, and then also the quicker to come down. And so the user then is ready for another dose. And that's what can kind of lead to this run or binge of repeated use, because it's such a fast acting drug that the person uses it again and again in order to experience that high, which only lasts for so long. For amethamphetamine and methamphetamine, smoking, which is called ice, or injecting in the bloodstream, both of these things happen quickly. So it's the same level of risk in terms of addiction and overdose as crack cocaine is. It can also be effective as an ingested pill, whereas cocaine doesn't really make it past the stomach if it's ingested in that way. And that's why methamphetamine and amphetamine were used in World War II rather than something like cocaine, because it could be administered via pills. And the effects last longer, for several hours, versus cocaine, which is over in about 40 minutes. So stimulants work by increasing the amount of monoamine neurotransmitters. These would be things like norepinephrine, epinephrine, dopamine, and serotonin. They're similar in that they're all monoamine neurotransmitters, but they kind of manage different parts of the body. And the norepinephrine and epinephrine are that stimulating kind of experience. They really mimic the activation of the sympathetic nervous system, the fight or flight response, whereas dopamine and serotonin would be the more euphoria-like effect, the feeling of high and pleasure that comes from the use of stimulants. They achieve this by blocking monoamine reuptake. So once the monoamines are released into the gap between neurons, the cocaine or methamphetamine stops them from being reabsorbed back into the original neurotransmitter. So there's more in the synapse, which means that it can keep activating the next neuron over and over and over again. So cocaine blocks the reuptake of those neurotransmitters, Amphetamine not only blocks it, but also pumps out more monoamine into the synapse. So it kind of it's like a 1-2 punch there in terms of the stimulating effect of the substance in the brain. And long-term use of both of these drugs really can deplete those neurotransmitters, something like 20% of dopamine decreasing as a result of the body's developing a tolerance to this. I mean, the brain is being flooded with these monoamines, especially in the case of methamphetamine. And so the brain stops producing its own as much because it's developing a tolerance to the amount that's present in the brain through the drug use. And so then that can cause some side effects, withdrawal symptoms like paranoia, irritability, and depression. But in this case, they can also be permanent because the body doesn't readjust back to the levels of dopamine it needs to function on its own. The acute effects of both cocaine and amphetamines, like I said, they really mimic the fight or flight response, that sympathetic nervous system response. And there are some potential positive effects. So these substances were used in a medical setting and can reduce the symptoms of asthma. They can contribute to weight loss through breaking down fat deposits for energy, that fight or flight response, but then also suppressing appetite. And they can lead to increased attention and concentration, but they can kind of go a step too far so that the effects are a little bit excessive and they can lead to like an increase or disrupted heart rate, ultimately heart failure if an overdose level is achieved. And that's what usually is going to be the fatal symptom, is this kind of cardiovascular effect of the heart rate just kind of getting out of rhythm because of the overactivation of the sympathetic nervous system. Like I mentioned before, we've got the specific effects would be increased attention, alertness, not feeling sleepy, but feeling like you have a lot of energy, having stamina, fidgety, feeling like you need to move a lot, feelings of euphoria and a sense of well-being, like feeling really good, feeling kind of on top of the world, not experiencing having an appetite, so not appetite suppressed, and some people experience an increase in sexual desire, but then their actual ability to engage in sexual activity is diminished. So this kind of frustrating position to be in for cocaine and amphetamine users. And at high doses, you can get things like feeling a euphoria level that's almost at the level of mania. So like an overconfident, delusional level of grandeur and well-being, repetitive actions like picking at the skin, becoming fixated on mundane particular tasks, and then even a psychotic-like state, reaching, again, like that sense of delusion of grandeur, or even hallucinating like crack bugs, like is a symptom of feeling like there are bugs under your skin. And that's something that can happen with both cocaine and amphetamines. Ritalin is another type of stimulant that's worth discussing. So this is frequently prescribed to treat ADHD, which is attention deficit hyperactivity disorder. Ritalin helps to improve attention and seems to factor into that executive functioning that's happening in the frontal cortex. So things like organizing your behavior to achieve a goal. So being able to plan and manage your time and complete activities towards a goal. But there is some concern and controversy about this. So the first is that ADHD is notoriously difficult to diagnose. It's something that we rely on self-report for. We do have some testing that we can do to be a little bit more scientific about the process, but it's not always accessible. And a lot of times it's really based on behavioral observations. And there can be biases in that, especially in terms of gender differences in ADHD and what we expect and how we expect young girls and young boys to behave can lead to some differences in the way we diagnose ADHD. So medicating based on a potentially faulty diagnosis is one controversy or complication here in terms of prescribing Ritalin to children. And then it begs the question, is this effective treatment or are we drugging kids into submission? So again, this idea that kids should be able to sit still, they should be able to pay attention and focus, they should be able to accomplish this particular type of work in the classroom, but those expectations may be unrealistic for some children. And so does that mean that they have a disorder and we should give them medications? Or does it mean that maybe we should rethink the way that we're teaching them or what our expectations are for them? The other thing that happens with the prescription of Ritalin to kids is that we then end up focusing on just the medication. Are you taking your meds? Are you taking your meds? Versus other interventions like behavioral therapy, which can also be effective. And again, we're helping increase attention and focus, but does that then actually help them learn better? And there's mixed evidence to support that in the research. So again, are we just drugging them to get them to behave in the classroom, or is it really in their best interest in terms of their ability to learn and engage with the material? The jury's still out on that. And then there are also side effects. So the experience of stunted growth, decreased appetite, and anxiety symptoms are pretty common when it comes to Ritalin, and this is being given to children. So that being said, for people who do have ADHD, Ritalin, they describe it as needing it to feel normal and to feel like they can function in the world as we've set it up. So even if we are drugging kids to meet some standard that we have, the fact remains that we do have that standard. And this is the way that their educational experience is going to progress for the next several decades, potentially, especially if they go to college. And so maybe that medication then is necessary in order for them to succeed with the system that we have set up. So your lecture question for this week in this module is, what are the pros and cons to using Ritalin as an ADHD treatment?